So welcome to this webinar on conversation on health equity and precision medicine. So is global precision medicine possible? And this is brought by Cambridge Prism's Precision Medicine. So I just wanted to say we do recognise that this topic is incredibly vast, and with a single panel, there's no way we can cover everything, but we have brought a knowledgeable panel today together to contribute to those ongoing discussions on health equity and disparity in access to healthcare in the context of precision medicine. So some items just quickly to cover for housekeeping reasons. This event is being recorded and the recording will be circulated following the event. Please do pose questions throughout the event in the live Q&A section, and we have reserved the final 10 minutes for answering as many questions as possible. And finally, we just ask that all cameras and microphones remain off throughout the event. So for today's event, I'm going to pass over to the co-chairs after introducing them. So we have Professor Dame Anna de Mintzak, who's the Regius Professor of Medicine at Glasgow University and is also Editor-in-Chief of the Precision Medicine Journal. Anna is also Chief Scientist of Health for the Scottish Government. And joining Anna is Professor Bina Joe, who's the Director of the Centre for Hypertension and Precision Medicine, a Distinguished University Professor, and is Chair of Physiology and Pharmacology at the University of Toledo. Anna, please can I pass to you?
Thank you very much. Thank you, Jess. And thank you to everybody for attending today's webinar on global precision medicine. I know we are going to have an interesting discussion on the challenges and opportunities surrounding implementation, adoption of precision medicine globally. We have selected a panel with great and diverse experience who can give us all-round view on this topic and highlight the most important issues for discussion. So, Bina.
Thank you, Anna. I would also like to thank you for attending today's event and now briefly introduce our panel to you. We have Dr. Natalie Zeib, who's a tenured and board-designated professor at the Department of Pharmacology and Toxicology, American University of Beirut Faculty College of Medicine, and Professor Anna Shub, who is a professor in the Department of Oncology at the University of Oxford. Since 2019, she has also been a senior faculty member at the Muhimbili University of Health and Allied Sciences in Dar es Salaam, Tanzania, and that's where she's joining us today from. Sophie Peat is a policy and stakeholder engagement manager at Genetic Alliance UK, as well as a member of the ATMP Engage, which is a multi-stakeholder group collaborating on patient and public involvement activities in relation to advanced therapy medicinal products. We have a number of questions we have decided on to give a good introduction to the topic area to pose to the panel. And as Ms. Jones just mentioned in the introduction, please post any questions you have in the live chat, and we'll cover as many as possible in the final 10 minutes of the event. Off to Anna for your first question.
So that's great. Thank you. Our first question will start us on discussion. What are some of the biggest challenges and early successes in achieving this equitable access to precision medicine across many different countries, different regions? And we would like first Anna Shub to address this, and we'll move to Natalie. Anna.
Yeah, thank you very much. And thanks to everybody for joining. A very interesting discussion, hopefully in the next hour. The first thing to say is that there are probably lots of opportunities, not just challenges with respect to global precision medicine. The challenges, though, can be broadly summarized in diagnostic challenges and challenges around the access to medicine. Within the diagnostic challenges, 47% of the world population does not have access to any diagnostics. So whether it's precision diagnostics or any diagnostics. So to give the right treatment to the right patient at the right time, when you don't have any tools, is kind of a real big challenge for half of the world's population. If you're thinking about specific diagnostics, in particular genomics, there are huge challenges around the African genome and other ethnicity genomes, because we simply haven't got them in our databases at the moment. So without genomics, it's hard to think about the narrow definition of, realizing the narrow definition of precision medicine. When it comes to access to medicine, we have challenges around regulatory hurdles and obstacles, challenges around the cost of medicine, of course, counterfeits and validating generic medicines. That's just to name a few challenges. I think the opportunity here is, but it's also a challenge, is to empower communities to run their clinical studies in their own ethnic groups and in their own localities, because that will provide access to medicine. If you ask me what is the biggest challenge of all, having worked on a global health program, I think it's probably the cultural differences and really trying for us to overcome our global north perspectives to some extent, and to start listening to the global south, and to start to understand really what their needs and perceptions are of medicine, and what it means for other cultures, so people from other cultural backgrounds, what research means for them, what medicine means to them, healing means to them. We're currently still living in a culture of mistrust, and to some extent, and I think we need to overcome that if we want to create a global medicine that is sustainable, ultimately also for us in the global north.
That's great, Anna. Thank you. I wonder, Natalie, if there are some things you would like to add from your perspective.
Yes, hello everyone. Thank you for inviting me to be part of this very interesting panel. So I can expand on Anna's comments, since I come from a different part of the world, a low socioeconomic place where we have our own challenges. So yeah, I agree with what Anna said, but more specifically, for example, it's not only that we don't have access to medications. Sometimes we cannot even afford the test, and sometimes we are asked to do some very expensive precision medicine diagnostics, such as for immunotherapy, and immunotherapy is very expensive. Maybe we should focus on treating with medications that do not necessarily need precision medicine, such as simple cytotoxic drugs. So precision medicine is definitely very important to give the right dose, the right drug, the right time to the right person, but sometimes it's too expensive and not feasible. This is one thing. Also, in our part of the world, we don't have much data, and many times precision medicine is based on data coming from the US, from Europe, from the UK, and it's not necessarily applicable to us. We need to generate data here to have our own genotype that may be associated with a different phenotype. We also may have different diseases, communicable diseases in contrast to non-communicable diseases. So yeah, all the challenges are really a lot, but it's okay, we're getting there. Just to end on a positive note, a lot has happened over the past 10 years, and hopefully with some collaborations, the challenges will be much less. Thank you, Anna.
Thank you very much. Bina.
Yeah, thanks, Natalie. Dovetailing on that first question, how can precision medicine be adapted to address the specific health needs and cultural context that you mentioned about of different populations in the world?
Yeah, so culture was actually mentioned by Anna earlier. Definitely culture has a lot of effect on our decisions, on we as researchers, as practitioners, patients, community, the government, etc. Maybe the biggest part is lack of knowledge And that is not only for patients, the government, but also for physicians. And trust also was mentioned. So there is the mistrust, and also sometimes there is overtrust. For instance, in some developing countries, the patients may actually overtrust the physician or the practitioner and do whatever they say. However, maybe the physician is not well informed and hence not asking for a specific diagnostics for precision medicine. So the patient may be misinformed, and the physician also may be misinformed. So the trust, there are two ways for the trust. And we worry what would happen to our data, because many times when we do next generation sequencing and all this high throughput genotyping, etc., our data is shared with outside countries, and we don't know what will happen to them. And we're afraid of being stigmatized if there's any breach of confidentiality or privacy. And which brings me to the last point, and that is informed consent. You know, when we do research or when we practice precision medicine, the most important is informed consent. You tell your patient what we are doing and what is expected. But culturally, it's not easy to do informed consent. How do you do it? Who does it? Are we sure the patient understands what we're asking? The language barrier. The informed consent may be written in English, but you want to adapt it to the language of the country. And autonomy. Are we really sure that the person is signing or accepting the research or the diagnostic in full autonomy, or there is some pressure from the family, the partner, etc. So a lot of cultural issues that one has to address for that matter.
Anna, do you have any thoughts on how precision medicine can be adapted to address these needs from your experience?
Yeah, I mean, I agree with and I concur with everything that Natalie said so far, and there's not much to add really. I think from my perspective, the indigenous knowledge, what I call indigenous knowledge, is really important. Also, I think when we are kind of coming from the global north perspective, we're thinking about very scientific, evidence-based, westernized medicine, and that's not necessarily the general understanding of medicine in other cultures. And while I'm totally convinced that our approach is, in the rational approach, evidence-based approach is the right approach, because obviously I was raised in the system, I also think that we need to be open towards listening to alternative approaches, and possibly in the context of palliative care, for example, in the context of chronic disease, where we still often do not have the answers, and I think it will be good from our perspective. That's where our cultural problem comes in. I think we always seem to have answers for everything when actually we don't, and it might be quite nice to kind of simply accept that and to start listening to to other approaches, which will lead ultimately to equitable, more equitable, not just healthcare, but also more equitable research, more collaborative research, and a more holistic approach to this whole question of what precision medicine actually is. I guess it will also save us some money, because clearly, if we are trying to realize, I'm always using CAR T cells as the example. If we're trying to realize this for the entire world, I think many healthcare systems, even in high-income countries, are struggling, and we do need to find other ways to practice medicine. That's what I feel more and more strongly, actually.
Thank you, Anna.
Great. I think we can move to the next question, which will go to Sophie Piet. And we're really interested in the findings from the Genetic Alliance UK, which focused on the barriers to equity of access to precision medicine. And although these are UK data, data, or try to see whether that can be generalized. So, Sophie, a little bit on your report and what we can learn.
Yeah, absolutely. Hi, everyone, and thanks also for inviting me to speak on this topic. It's been really interesting hearing what the other panelists have said so far, and looking forward to the discussion and the Q&A later. So as Anna mentioned, I'm from Genetic Alliance UK, which is a charity that supports and advocates for people living with rare and genetic conditions. So in our context, when we're talking about precision medicines, we are mostly talking about cell and gene therapies, or also known as ATMPs, advanced therapy medicinal products, because they have potential to either cure or significantly improve the outcomes for people living with rare and genetic conditions. Genetic Alliance UK is a patient organisation, so I really wanted to take the opportunity today to kind of speak to the patient perspective on equitable access to these types of medicines, because the very nature of precision medicines, they have the potential to magnify existing inequalities that are already experienced by some patients. And so therefore it's a perspective that we really have to consider when we're kind of developing or delivering any of these types of medicines. So earlier this year, we carried out some research that looked into equity of access of ATMPs in the UK, which consisted of searching through academic literature, grey literature, and also a roundtable discussion with some experts. We then produced a report on behalf of ATMP Engage, which is a group that brings together UK-based stakeholders with an interest in ATMPs to collaborate on patient and public involvement and engagement activity, so PPIE activity. The report summarises themes and it has calls to actions for specific stakeholders in the UK, and I'm happy to share the link to that report for anyone who wants to read it in full. Several themes arose from that piece of research, and I don't have time to talk about them all today, but I just wanted to highlight on a couple of them. So firstly, I wanted to talk about a theme that arose around the barriers that exist, which may create inequalities with respect to patients engaging with these types of therapies. So to kind of put that into context, for example, an ATMP treatment might be considered a one-off treatment, but it can still require quite a lengthy stay in a hospital or a clinic, and that can be very far from home. So that impacts a person's ability to maintain employment. If it's a child that's affected, quite often a parent will still have to kind of sacrifice their employment or their work to stay with their child, if it's not close to home. There's also quite a lot of follow-up appointments that might happen even after this one-off treatment, and that can take up a lot of time, especially again if they have to travel quite a long distance to go to these appointments, and that travel might be quite expensive to get to. And these factors have a direct financial burden on individuals and families. So even if the therapy is provided for free on a service like the NHS, it's still those that are more financially resilient are probably more able to engage with these therapies because of these other factors. And these kind of financial burdens will be kind of felt more by those households that have lower incomes. And this is something that is we found in our UK research, but is something that I imagine will be replicated in other countries around the world too. During the roundtable discussion, it was also suggested that these kind of inequalities might actually be quite difficult to see in a clinical trial setting compared to a real world setting, because clinical trials are well resourced to deliver well coordinated treatment. They reimburse all expenses very promptly, whereas in a real world setting, resources are much more limited. Coordination between specialist centres, which is where quite a lot of these therapies might have to be delivered, and local services are likely to be much less efficient. As a result, there was a recommendation actually that came out of the roundtable discussion to closely monitor patient experiences when receiving these types of treatments, so that we can identify the impacts as early as possible and minimize them accordingly. There were also concerns from the kind of roundtable discussion around the clinical trial recruitment being potentially biased towards individuals and families who need less support, because they might be more willing to consent and participate in clinical trials, again because of these reasons that I've talked about. The second theme I just wanted to touch upon was the importance of good communication and clear information in supporting equity of access. So this was a theme that came up repeatedly, and it more or less underpinned quite a lot of our findings. The novelty of precision medicines and things like cell and gene therapies and ATMPs and the complexity of these types of medicines kind of causes a communication challenge from the start. Not everyone is going to understand what they are immediately. So therefore, kind of potential patients, families, and even healthcare professionals need trusted sources of information. There's a lot of information out there that's quite easily accessible, but the quality of that information is highly variable. And I know some of the panelists have kind of touched upon some of the cultural distrust that exists in some communities. And this was a theme that also arose through our research, and therefore the need for kind of culturally sensitive communication being essential in improving equity of access. I just kind of wanted to end on the note that I'm aware that this is a UK-based kind of research that we've done, and we're looking at a global picture here, but with the research that we did, we found that most of the resources were either American-based or European-based, so kind of highlighting the fact that there might need to be some further work done to understand if these barriers exist in other parts of the world or not. There may be overlaps, but I also imagine that there will be significant differences, and we need to understand that a bit further in order to begin to overcome some of these inequalities.
That's great, Sophie. As you now have this global platform for further 30 minutes, could you think about a call for action to truly try to ensure that there is equity at all levels, at all stages of the pipeline of precision medicine from what you've learned? Could you give us a call for action?
Yeah, absolutely. So, as I've just kind of touched upon, I think there is further work to understand the patient perspectives in different countries as well, understanding the barriers that may exist, and hoping that our kind of report and that our research might just be the beginning of that conversation. But additionally, I really want to emphasize the value of involving patients, their carers, and family in all stages of development. So that's kind of from the research all the way through to delivery. If you involve patients in the planning stages, you are going to better understand what the potential barriers might be with respect to for patients engaging with these therapies, and you can therefore minimize them as much as possible before they even arise. And you cannot get these perspectives without engaging people from the community, especially kind of, engaging people that are likely to be on the receiving end of these therapies. Their insight is invaluable and irreplaceable. So that would be my main call to action.
Great. Thank you very much, Sophie. That's hugely important. Thank you. And I pass to Bina.
Yeah. So far, it's been a great discussion around challenges and call for actions, etc. But we are getting into the AI era. So can one of you, Anna, comment on the value or the role of technology where resources could be limiting?
Yeah, thank you. I mean, we've all heard about the mobile phone and how the mobile phone transformed in communication on the sub-Saharan in sub-Saharan Africa compared to the landline. So it's a great example of leapfrogging, hugely successful, has influenced the way people are banking, people are earning money, people are communicating. And I truly believe that in medicine, there's many examples of where we can leapfrog, where we basically, not copy and paste the same mistakes that we've made in the global north, but actually, go onto something different. So the issue with that, of course, is that these technologies need adaptation, validation, development, rigorous processes. If it's diagnostics, they need clinical accreditation to some ISO standard or some form of clinical standard anyway. When it comes to AI, I think, it's a buzzword, isn't it? I mean, I'm thinking mainly the first instance is, can we make use of technology in better reaching out to patients, for example. And there are great examples of that, Babylon and other examples where we can start to engage with even remote communities. We can do things like sending samples away to central places for testing, which is great. And then of course there's the whole, in the genomic front, there's this whole idea of locally testing, but actually centrally analyzing and being in the cloud, working in the cloud together. And so we in Tanzania, Uganda, we have a great example of that up and running, where we used liquid biopsies to speed up the diagnosis of children with Burkitt's lymphoma, just using a blood test rather than going through surgical intervention and pathology. Now, the issue with that, of course, is that when you're using next generation sequencing, you then need bioinformatics, you need statistics, you need machine learning, you need all these skills. And those skills is not something that you can acquire in 6 months. So technology comes with actually a need for very fundamental knowledge in mathematics, statistics, computer engineering, software engineering. So it's not completely easy. On the clinical side, you need good clinical data. And we see the challenges in the United States where data is fragmented. Lots of different healthcare providers in most part of the world, with the exception of the United Kingdom and maybe Canada or smaller countries like Denmark. To pull data together is a huge challenge, because you've got the private sector, you've got the public sector, you've got churches running hospitals. It's not just about technology; it's about the training of people, and it's actually about organizing the data in a way that it's in a place in the end where people from across the world with the knowledge can analyze it.
Any of the other panelists have any comments on the technology?
Yes, hi, this is Natalie, and I can comment on that if I may. So what Anna said is so true, specifically infrastructure. So low middle income countries may not have the right infrastructure to deal with all of this next generation sequencing data, AI, as you said. And it can be even more than that, not just data analysis, data storage, data transfer. If we outsource our genotyping outside, and then how do you get it back? Where do you store it? What do you do with it? How do you analyze it? How do you transfer the data? So there definitely is a need for capacity building, training, as Anna said, and infrastructure. But this needs some thinking, because we probably need to do it slowly and think of what is really important right now and how can we strategize. And let me give you a very small example. Since I do pharmacogenetics research, I'm interested in genes and drugs. Instead of doing genetic testing for all genes or next generation sequencing and wait for the results and then act, we can actually just do a simple point of care test that is done quickly, cheaply, and apply precision medicine at the bedside really quickly, while at the same time storing some DNA for future experiments, for research to hopefully grow as we build. So we cannot just bring everything and apply it on the same day. It has to be gradual, if I might say.
Data acquisition is a point you all have touched on as the biggest problem. So if we compare and contrast with delivery of care aspect of it with vaccines, for example, we have been globally quite successful with vaccines, if you want to use that as a delivery of care point. Where does precision medicine stand for rare diseases, genome sequencing, etc., for delivery of care to each person on the global platform? I know it's a loaded question, but it's also probably a little premature, knowing where precision medicine is in the global north versus global south, like Anna put it. But what are your thoughts on these aspects of delivery of care versus the data acquisition point?
Whom are you asking, Bina?
Anna.
Anna.
Anna, how does it work in Tanzania versus the global north for delivery of care when it comes to precision medicine?
Well, so I would take up your point on the vaccines. I mean, you're totally right. There have been tremendous successes when it comes to the vaccination programs, and it's not my area of expertise, but I imagine that this is something that people have been used to for a long time. Infectious diseases, the communicable diseases have been around for a long time. They're managed in the public health arena. When I look at some of the universities in sub-Saharan Africa, when they train clinicians in research, they train clinicians in epidemiology and in public health. Those are the two main areas of training and research. For the non-communicable diseases, I think we have to look at individuals, like you rightly say. Vaccines you give to everybody, or almost everybody. Here you're talking about non-communicable diseases. You are talking about huge challenges around diagnostics. Cancer, you can't just diagnose cancer. You can't just treat cancer. You can't just give a vaccine to cancer. You have to actually know what type of cancer it is. For that, you need pathologists. You need tissue. You need so it's just the challenges that we are facing in delivery of care in sub-Saharan Africa is huge, because we still haven't managed to kind of finalize the infectious disease problematic, and we are already being faced with patients aging, patients getting diabetes, getting cardiovascular disease, and then also having malignant diseases. So it's doing this in parallel is a huge challenge, I do think that the vaccination is a really good example, but it's also quite an easy example. Whereas the challenges we face in the non-communicable diseases is a much greater one, unless we realize actually, and here's the opportunity: 25% of cancers in the global south are actually infection related. So why are we not developing vaccines against EBV, for example? Now it's coming because in the global north we have a problem with multiple sclerosis. For years, for 50, 60 years, kids in Africa died of Burkitt's lymphoma. It's EBV driven. There was no interest by pharma to develop the vaccine because the market wasn't there. So there are those even within those opportunities, because you think it's a no-brainer to develop a vaccine for infection-related cancers, but if it takes 40 years to develop that cancer, it's too long for pharma to see the endpoint. So those are but I still think, hepatitis B, EBV, HPV, of course, these cancers should no longer exist on Earth with the current vaccine strategies that we already have.
Yeah, amen to that. Yes, a lot of it is, if I may use the word, a little bit bureaucratic too, right? For science can deliver, but it becomes very difficult at the point of delivery of care for this to occur in an efficient manner. Thanks, Anna. We'll now move on to some questions from the chat and come back to this discussion. I see a few questions there. So first off, there are certain countries that are leading the current precision medicine healthcare frameworks and have the most investment, for example, the US, Sweden, and UK, etc. Do you think they've successfully implemented precision medicine in a way that can be emulated around the world? Natalie, do you want to address that?
All right, hi, I'll try. The short answer is no. The long answer is this needs time. So definitely the data and the clinical applications that are happening in the US, Europe, etc., they are helping us to launch research. So whatever research was done and now is applied in the clinic in the North, if you want to call it, is being researched again here. And we're not repeating the same thing. We're not doing a Me Too research, but you really have to see whether the same genes, the same phenotype, the same associations apply here. This is concerning the science and the evidence. And also you want to see whether this is feasible, whether there's acceptance, does it work culturally, etc. So it has helped us to move forward, but we cannot just simply take the results from the north and apply it in the clinic on the very second day. Unfortunately, this is not possible, but we're getting there. There will always be a lag of 10 to 20 years, if I may say, and this is how it is.
Huge. Yeah. Anna, would you
Well,
like
maybe
to?
I can, yeah,
Yeah.
I can add to that. I mean, the first thing is I don't think we've implemented precision medicine in the north, even despite of all the investment. So, you know, it's not equitable in the north. Even in the UK with the National Health Service, it's not equitable. You still find, you know, in some instances, it's difficult to get, you know, even in my field, get a TP53 mutation analysis done on time on a patient can be a challenge. We have lots of data from the US and also from European surveys showing that, you know, only half of the patients who should receive you know, pre-testing for mutation analysis in leukemias, only half of them will actually get it. There's issues around the education of physicians. Physicians think, oh, it's not needed. They're busy in a clinic, they're simply not doing it. Maybe where do they send the samples to? They might not know. The lab might not be able to process it, etc., etc. So the multitude of hurdles and inequalities, and of course, you know, the more private healthcare driven the system is, the more unequal it becomes, I guess. I'm imagining. And the greatest so the issue we're facing now, when I'm kind of saying global south, global north, it's actually not like that anymore. It's actually within each country we have a global south and a global north. And so what I'm saying is there's huge inequalities in the UK, within the UK. There's rich people, there's poor people, and they have a difference in life expectancy, you know, of 10, 15 years now. So in the US, it's the same. Afro-Americans have lived far shorter than white Americans. And there are lots of, and we know this, and there are lots of reasons for that. It's not all, you know, it's not all the healthcare system's fault, but it's the implementation of precision medicine hasn't even happened in our settings. And I don't think it will unless we're actually learning from each other. And we kind of also try to find solutions, you know, elsewhere. And that's where that communication starts between the South and the North, and where we can learn from each other, I think.
Well, fascinating to hear that there is light at the end of the tunnel with polygenic risk scores already accumulated and research going on in developed nations for how we can make use of it, etc. So touching base on polygenic risk scores, can we pivot to ask this question from the audience? Aspects such as polygenic risk scores that underlie aspects of precision medicine are known to contain racial and demographic bias towards, is there a risk that precision medicine won't have a large impact or as much as an impact because of this difference? And are there any ongoing efforts to address this issue? I would direct this to Sophie first, and then our co-chair, Dame Anna Dominicek, who is a proponent of the polygenic risk score aspect, to answer this question for us next.
Thanks, Bina, and thanks for the question. Yeah, so the data that we have on genetic information is biased towards kind of a Northern global data set, really. That's where it's come from for the majority. And this was actually a theme that also came up in our report and our findings that I just didn't touch upon when I spoke about it earlier, is that there were themes discussed about, you know, who's involved in this research and understanding who's involved in the research, making sure that all research is diverse and representative of lots of different communities, to ensure that it doesn't kind of unintentionally have different impacts in different communities. so that we can kind of level the playing field. And I think one of the ways to sort of try and get around this, and there is some work going on to sort of overcome this and build our data set around this. But again, it kind of comes back to engaging with the communities, because we touched upon the kind of cultural distrust in research and medical professionals in some of these communities. We need to really work to engage these communities, address these barriers, understand what's holding them back from maybe being involved in this kind of research. So that, you know, if we engage these communities, we can understand that and overcome those barriers and start a two-way dialogue and kind of move forward and reduce inequalities in that way. Yeah.
Okay, so I would like to offer a little more optimistic view, because I am an optimist. And I would like to say that, of course, polygenic risk scores are very interesting. It's still, in majority of areas, research that needs to be done properly and evidence-based to go to the clinic, but there are some areas of great interest. And yes, it is true that because of the way research is done, the majority of patients who had genome-wide association studies in various polygenic traits have been from global north, and even to be more precise, they Northern Europeans or people of that ethnic Northern European origin. However, there has been a big effort over the last few years to increase the presence of other groups in the GWAS, genome-wide association studies in variety of diseases, because this is the only way. Of course, polygenic risk score is constructed from the raw data, the original data of GWAS, whether you look at hypertension, diabetes, coronary artery disease, or cancers, many cancers, you need GWAS first. So there is a lot of new funding that both in many of the countries, including US, Europe, UK, trying to increase. I have a slide, but I can't bring it on this moment, that shows how this is changing to the better. So people are aware of this. So we need more GWAS studies, not in Northern Europeans or people of this descent, and then we would be able to construct polygenic risk scores that could be tested for other ethnicities. The issue here is that the danger is to adopt without any change polygenic risk score from Northern European to Black Americans or whatever. It still shows things, but it would be much less precise, and science, in particular precision medicine by its very name, needs precision. So we are doing it. We need more work as always, but this is something that scientists, funding bodies, funders need to do. Can I come back for 1 minute in optimistic view on the previous question, if I may, very quickly?
Yes.
I think that there are certain parts of the health service, such as NHS, Anna showed, that are particularly suited to help us in making it better. Because if I agree with you, there are inequalities, but we can work on this because we have medicine that is generally free at the point of delivery. And there is no, I don't think we should put it in the same box as other things. So our work needs to be, Scotland is a great example, NHS, very important, very little of anything else. Could we give an example of being at the forefront of precision medicine that tries to reduce inequalities rather than make them greater? Just a touch of optimism for everybody. Thank you, Bina.
Sure. There is a third question, which comes back full circle to the vaccine aspect that we talked about. So I think it's on people's minds. Vaccination programs seem very successful in some of the areas you have mentioned. Is there anything that can be learned from these in bringing more precision medicine-based initiatives to these regions? I'm looking at Natalie or Anna, Shub or Sophie or anybody. It's an open question.
Well, Anna has already addressed the vaccine issue, and I don't think there's anything to add on my end, except something that is not really related to precision medicine, but it's really about very simple issue about acceptance. Before we talk about precision medicine and vaccines, we have a lot of people who do not want to be vaccinated, who do not trust the vaccination manufacturer, who think weird things about vaccines, and that is for me the biggest issue before talking about precision medicine and vaccination, especially in our area of the world. I don't have the numbers on top of my head here, but definitely not everyone got vaccinated for COVID. And for HPV, for instance, most of our women or teenagers do not take the HPV vaccine, although it's proven to simply decrease the risk of cervical cancer. It's already known. I don't know how it is in Africa, Anna, but in our area, we just do not vaccinate for HPV, although it is in the guidelines. For me, this is more important than precision medicine, if I may say, concerning vaccines.
Yes, I think I can add to that. I mean, it is I want to be positive. There are huge. There are challenges that we certainly learned a lot during the pandemic, I guess. And I think certainly what I learned was that we can only ever think that there will be a success in an intervention if we have the buy-in from the population, the healthcare workers, the healthcare system in whatever system we are operating. And I think for COVID and vaccines in general, that buy-in is not necessarily, but it has to be looked at in a very different way from the way we would look at it in the United States or in Europe. COVID was certainly probably for the majority of people in Sub-Saharan Africa a minor problem. Because they're young, fit, healthy, they're not part of the of a high risk group. Very different from what we saw, obviously, in the north. HPV, education plays a huge role. In Africa, people think when you have a HPV vaccine, it causes you to be sterile. So it's based on mistrust. So we're going round this round circle again. Do we need HPV vaccines to be produced on the continent? By local people, so that they understand it's not causing a sterilization. I don't know. I mean, I think these are areas of research in general. Coming back to the question, I think it is, and I've said this I think a couple of times now. It is really, really important that we do listen to our colleagues in those countries, and we don't helicopter research. We don't helicopter introduce clinical care, but actually there are a lot of colleagues in those countries. They are extremely well educated. Some of them will never return to their home after they've been trained in our universities, but a lot of them do eventually return home, and they are they're an incredible source, and I think we just need to tap into that source of people who are there and who are waiting to just to have a little bit of mentorship, and then they will be flying.
Yeah.
And I kind of just want to come in on Natalie's point around the kind of acceptance, and it kind of goes beyond the vaccines as well. With cell and gene therapies, for example, some people may not want to take a precision medicine, a cell and gene therapy, even if it might potentially be curative, because they have other alternative treatment options that manage their condition in a way that seems to suit them. So there's, acceptance isn't just kind of about vaccines, it's also about these other treatments as well. And there are patient preferences. I think there's one example around, for example, haemophilia. I think there is research around gene therapies that could potentially be curative for people with haemophilia, where they would no longer have to inject themselves with clotting factors. But for some people, they'd rather do that rather than risk having a precision medicine sometimes. So I think there is also a patient preference when it comes to acceptance of these types of medicines as well, that we have to be considerate of as well.
Well, to be honest with you, patient preference is actually very optimistic a stage. It is up to them versus the problems we're talking about up front for equity of access, equity for economics, equity for global stage collaborations, etc., in the political arena. Those are, big elephants in the room compared to a patient choice matter, right? That would be, for scientist perspective, be more optimistic. Well, it's not our problem that they're not choosing that. That's a right to choice. Although that is an important point to talk about when we consider through the pipeline for each individual. So last question I would go before handing it over to Anna, just for curiosity. If there is a condition such as a rare disease in a person in Africa or another impoverished country of lower economic standards versus a person with a rare disease in UK or US, forget choice of the patient, where are we today with diagnosis, data acquisition, delivery of care? Is the divide very big versus is it shrinking? Lastly, what is the wish list for where we should be? Anna?
Yeah, I mean, specifically, you're mentioning specifically rare diseases, so I focus on that. I think we don't have, we need to expand the genomic sequencing capability, and it's nice to hear pathogen surveillance. It's nice to hear that genome centers are being discussed on the African continent, not just in the context of pathogen surveillance, but also in the context of rare disease. Gene therapy of sickle cell disease, obviously something, Bill Gates, Novartis, others are hugely supportive of that. Without the diagnosis, without actually knowing the genome, we can't fiddle about in the genome. That's what I keep saying to people. So we do have to have very complete understanding of the African genome before we can start talking about gene therapy, be it for hemophilia or sickle cell or indeed any other rare disease. So at the moment, Anna is right. There's GIVA studies have been run. 10,000 patients have undergone GIVA's testing with an African-specific array, and that data is now available thanks to H3 Africa. However, that is not going to give us the degree of resolution, I think, that we need to diagnose all rare diseases. So there's still a lot of work that needs to be done, and ultimately, I think that this, Amro's call for the 3 million African genomes, I think that is basically what needs to happen.
Well,
okay. I think, Bina, we need to go to our final question,
right,
which is to everybody who would like to answer. And it's basically closing question for the panel. Could we have a sentence from anyone who wants to give us a sentence that will emphasize the value of international collaboration in all this? I think what we heard is that, yes, it needs to be local, but there also needs to be collaboration globally to implement the best for patients and communities. We haven't touched or vaccines, yes, preventative medicine, hugely important. So precision prevention is also important. So give me a headline news about global collaboration.
Hi, this is Natalie. Well, if I want to give a quick answer, what we are doing today, this symposium, this panel, is actually all about collaboration. We asked the same question to different people, and already we had ideas, we shared different points of view. This is the ultimate collaboration, and this is how science should be, the clinic should be, and research should be. We cannot work in silos. It's all about collaboration, and now collaboration has become much easier because it's not the global south or north, it's the whole earth. We are all one. So that would be my summary, if you'd like, Anna.
Fantastic, Natalie. Could we get something from Sophie now and then from Anna? Sophie.
Yeah, absolutely. So an international collaboration is really essential in addressing inequalities. There's no point kind of reinventing the wheel. If you've learned something in one place that can be applied elsewhere, you know, why start from scratch? So I think, yeah, just having that kind of collaboration. And I'm always going to say from the patient perspective, you know, the engagement on a kind of global network as well is invaluable.
Okay, Anna, last word on this.
Well, no, I don't have much to add. I think, I mean, I really think it's about listening to each other, changing our way, you know, forging true collaborations with the entire world, not just amongst us.
That's absolutely fantastic. I think we all agree there is no you know, contrasting opinions here. There was a question we didn't answer, which was about, does it always have to cost more? And we in Scotland have quite a bit of very elegant health economic evidence that in fact being precise could cost less. And a great example of this is the pharmacogenomics as part of precision medicine agenda. If you save on adverse reactions, you save a lot. So doing medicine right costs less, not more, and could save health services enormous amounts of money. And we need health economists to show this to budget holders, governments, people who run the show, because that's the way to progress, I think. So I would like to thank really the panel. You've been all great. Thank Cambridge Press, Cambridge University Press for all the preparations. I would also like to invite you all to the next webinar of precision medicine, which will be precision medicine in the community, and it's next week. So please register. It's available online already. It is going to be extremely exciting. And thank you, our panelists. Thank you, Bina, for co-chairing, and thank you, Jess and colleagues from Cambridge University Press. Thank you so much.
Thank you all.